Hello, and welcome to the IRF and LTAC Virtual Training Program, Part 1. My name is Charlotte Stininger, and I'm presenting Section D, Patient Mood Interview and Total Severity Score. I'm a registered nurse with experience in acute and post-acute direct care, nursing education, and quality management, specifically in the home health setting. Currently, I'm a senior staff associate at Econometrica in Bethesda, Maryland. At the conclusion of this training, you should be able to describe D0150 patient mood interview, the PHQ 2 to 9, and D0160 total severity score items that are new for inpatient rehabilitation facility and long-term care hospital providers. Identify the intent, coding instructions, and interviewing tips for the Patient Health Questionnaire, PHQ 2 to 9, and total severity score. Now note, Section D is comprised of more items than D0150 and D0160, but this presentation will focus solely on those two. So we'll start with an overview of these two items, the patient mood interview and the total severity score. As I mentioned before, D0150 patient mood interview, the PHQ 2 to 9, and D0160 total severity score are both new for IRF and LTAC providers. D0150 patient mood interview is comprised of the PHQ-2, and along with the remaining 7 questions make up the PHQ-9. Once the patient mood interview is done, you would complete D0160 total severity score. The items in Section D address mood distress, a serious condition that is underdiagnosed and undertreated in the post-acute care or PAC setting. It's important to identify signs and symptoms of mood distress among patients in the PAC setting because these signs and symptoms can be treated. Now, something to remember, the presence of indicators in Section D does not automatically mean that the patient has a diagnosis of depression or other mood disorder. So let's start with D0150 patient mood interview, the PHQ 2 to 9. We begin with defining the PHQ 2 to 9 known as the Patient Health Questionnaire. This is a validated interview that screens for symptoms of depression, and it provides a standardized severity score and rating for evidence of a depressive disorder. It's important to understand that depression can be associated with psychological and physical distress, decreased participation in therapy activities, decreased functional status, and poorer outcomes. Mood disorders are common in the PAC setting and are often underdiagnosed and undertreated. Assessment timing is key for this item. And for IRF and LTAC, if you are performing an admission assessment, complete as close to the time of admission as possible. And if a discharge assessment, complete as close to the time of discharge as possible. Now for LTAC, complete only if A0250 is 1 admission or 10 planned discharge. Let's review these steps for assessment for D0150. First, conduct the interview in a private setting if possible. Interact with the patient using their preferred language. Be sure the patient can hear your voice and/or have access to their preferred method of communication. If it appears the patient is unable to communicate, offer alternatives such as writing, pointing, sign language, or cue cards. To continue, if an interpreter is used during the patient interviews, the interpreter should not attempt to determine the intent behind what is being translated, the outcome of the interview, the meaning or significance of the patient responses. Sit so the patient can see your face. Minimize glare by directing light sources away from the patient's face. Also, be sure that the patient can hear you. Patients with hearing impairment should be tested using their usual communication devices or techniques as applicable. Try an external assistive device, headphones or hearing amplifiers, if you have any doubt about a patient's ability to hear. Also, minimize background noise. And it's important, when administering the PHQ 2 to 9 assessment using a paper form, be sure that the patient can see the print. If necessary, provide accommodations to ease reading. For example, provide the form in a larger print or provide an assistive device such as a page magnifier. Before you start, explain the reason for the interview. Suggested language in the guidance includes, I'm going to ask you some questions about your mood and feelings over the past 2 weeks. I will also ask you about some common problems that are known to go along with feeling down. Some of the questions may seem personal, but everyone is asked to answer them. This will help us provide you with better care. It's important to explain and/or show the interview response choices. A cue card with the response choices clearly written in large print may help the patient comprehend the response choices. The guidance provides some suggested language. I'm going to ask you how often you've been bothered by a particular problem over the last 2 weeks, and I will give you the choices that you see on this card. Now then, show the patient the cue card and describe the response options by saying your response choices are 0 to 1 day, never or 1 day, 2 to 6 days, several days, 7 to 11 days, half or more of the days, or 12 to 14 days, nearly every day. Moving on to step 9. Determine if the patient is rarely, never understood verbally, in writing, or using another method. If the patient is rarely, never understood, code D0150A1 and D0150B1 as 9, no response. Leave D0150A2 and D0150B2 blank in the PHQ-2 interview, and leave D0160 total severity score blank. Okay, so we start by asking the first 2 questions, D0150A and D0150B, of the patient mood interview. Now, the questions we ask regarding those 2 items are the following. Over the past 2 weeks, have you been bothered by any of the following problems? Then list the problems or symptoms that are included in D0150A. Now, this question is about determining if the patient is bothered by the symptom. This is not our perception or our assessment of the symptom presence, meaning that we don't score this item based on our assessment or determination if the patient actually has these symptoms. This is all based on the patient's report. So we will cover coding instructions for these response choices a little later in the presentation. Remember, it is important for each question to read the item as it is written. Do not provide definitions. The meaning must be based on the patient's interpretation. For example, the patient defines for themselves what feeling down means. Each question must be asked in sequence to assess symptom presence, column 1, and symptom frequency, column 2, before proceeding to the next question. Remember, when coding symptom presence, enter code 9 in column 1 and leave column 2 blank if the patient was unable to complete the assessment, chose not to complete the assessment, or responded nonsensically. A nonsensical response is a response that's unrelated, incomprehensible, or incoherent, or the patient's response was not informative with respect to the item being related. For example, when asked the question about poor appetite or overeating, the patient answers, I always win at poker. Now let's consider. If D0150 column 1 symptom presence is yes, use the response choices in D0150 column 2 symptom frequency. Ask the patient the number of days that they were bothered by the symptoms, read and show the cue card with frequencies and category descriptions. Once you score the first 2 items of the patient mood interview, you will need to determine whether to complete the PHQ-9, meaning ask the remaining 7 questions, D0150C through D0150I. Whether further evaluation of a patient's mood is needed depends on the patient's response to the PHQ-2, D0150A and D0150B. If both D0150A1 and B1 are coded 9, or both D0150A2 and B2 are coded 0 or 1, end the PHQ interview, but otherwise continue. So let's explain this a little bit more. If both D0150A1 and B1 are coded 9, leave D0150A2 and B2 blank, then end the PHQ2 and leave D0160 total severity score blank. However, if both D0150A2 and B2 are coded with a 0 or a 1, then end the PHQ-2 and enter the score from D0150A2 and B2 in D0160 total severity score. Now, for all other scenarios, proceed to ask the remaining 7 questions, D0150C through D0150I of the PHQ-9, and complete D0160 total severity score. Now, that's a lot of ifs and ands, so let's break this down a little more visually. Let's think about a scenario where a patient is rarely never understood verbally. So the symptom presence for the first 2 items is coded with a 9 and symptom frequency is left blank. So if D0150A2 and B2 are blank, then there is no need to continue the PHQ-9. In the PHQ-2 patient mood interview and leave D0160 total severity score blank. Now let's think about a scenario where both symptom frequencies for the first 2 items are coded as a 0 or a 1. So if both D0150A2 and B2 are coded with a 0 or a 1, then there is no need to continue the PHQ-9. You will end the PHQ-2 patient mood interview and then enter the total score from D0150A2 and B2 in D0160 total severity score. Here are a few other scenarios for when you would complete the remaining 7 questions and complete D0160. So if D0150A2 and D0150B2 is a 2 or a 3, or if either are scored as a 2 or a 3 and the other is scored with a 1 or a 0, then you would ask the remaining questions and complete D0160 total severity score. These are the remaining 7 questions I've been talking about, meaning that you will ask your patient about the symptom presence for these remaining items. So let's review this. Remember, you will ask first about symptom presence by saying, over the last 2 weeks, have you been bothered by any of the following problems? Then you would code the symptom presence for that item. Code 0, no. If the patient indicates symptoms listed are not present, then you would enter a 0 in column 2, symptom frequency as well. Code 1, yes, if the patient indicates symptoms listed are present, then you would enter a 0, 1, 2, or 3 in column 2, symptom frequency. Code 9, no response, if the patient was unable or chose not to complete the assessment or responded nonsensically. Leave column 2, symptom frequency blank. Enter a dash in column 1 if symptom presence was not assessed. So in these coding instructions, you can see in some cases how the coding of symptom presence can define how symptom frequency is coded as well. Then for the same item, you'll ask, about how often have you been bothered by this? Then consider the response options for symptom frequency. Those symptom frequency options are the following. Code 0, no, never, or 1 day, if the patient indicates that during the past 2 weeks they have never been bothered by the symptom or they have been bothered by the symptom on 1 day. Code 1, 2 to 6 days, several days, if the patient indicates that during the past 2 weeks they have been bothered by the symptom for 2 to 6 days. Code 2, 7 to 11 days, half or more of the days, if the patient indicates during the past 2 weeks they have been bothered by the symptom for 7 to 11 days. And finally, code 3, 12 to 14 days, nearly every day, if the patient indicates that during the past 2 weeks they have been bothered by the symptom for 12 to 14 days. Now, here are some coding examples of how to code symptom presence and when that symptom presence directly informs what you do with symptom frequency responses. For example, if column 1 is a 0, then column 2 is also a 0. If column 1 is a 9, meaning no response, then column 2 is left blank. If column 1 is a dash, meaning no information, then column 2 would also be left blank. Remember, you should attempt to conduct the interview with all patients. However, if no assessment is conducted for the patient mood interview, then in each row, D0150A through D0150I, enter a dash in column 1. You would then leave column 2 blank and code 99 for D0160 total severity score. It's important to understand that patients may respond to questions verbally by pointing to their answer on the cue card or by writing out their answer. But remember, select only one frequency response per item. Consider if the patient uses their own words to describe a symptom, this should briefly be explored. If you determine that the patient is reporting the intended symptom, but using their own words, ask the patient to tell you how often they were bothered by that symptom. Okay, let's look at this important coding tip. If the patient has difficulty selecting between two frequency responses, code for the higher frequency. Now, some items like D0150F, feeling bad about yourself, or that you are a failure or have let yourself or your family down, contains more than one phrase. If a patient gives different frequencies for the different parts of a single item, select the highest frequency as the score for that item. Now let's take another look at a scenario for coding both D0150 and D0160, and hopefully this will help clarify your understanding of this concept. If D0150 A1 and B1 are both coded with a 9, then leave the symptom frequency blank for both items. You would skip the remaining items, and you would also leave the total severity score blank. Coding for the PHQ 2 to 9 may feel uncomfortable, as you sometimes may be addressing very sensitive subjects. For example, consider D0150I, thoughts that you would be better off dead or of hurting yourself in some way. Beginning interviewers may feel uncomfortable asking this item because they may fear upsetting the patient or may feel that the question is too personal. Others may feel that it may give the patient inappropriate ideas. However, experienced interviewers have found that most patients who are having this feeling appreciate the opportunity to express it. Asking about thoughts of self-harm does not give the person the idea. The best interviewing approach is to ask the question openly and without hesitation. Okay, now let's review some interviewing tips and techniques. You can repeat a question if you think that it has been misunderstood or misinterpreted. Some patients may be eager to talk with you and will stray from the topic at hand. And when a person strays, you should gently guide the conversation back to the topic. Some examples are maybe say, "That's interesting, now I need to know," or "Let's get back to," or "I understand. Can you tell me about?" Now let's take a few minutes to learn about some specific interview techniques that can be utilized to help a patient identify either symptom presence or frequency. First, there's clarification. Using clarification, you validate your understanding of what the patient is saying. You can say to the patient, "I think I hear you saying," or "Let's see if I understand you correctly," or "You said blank. Is that right?" Unfolding is a technique where you offer a single frequency response and follow with a sequence of more specific questions. Now, this is an excellent technique for when your patient reports being bothered by a symptom, but can't seem to identify a symptom frequency. So, for example, you would say to your patient, "Would you say feeling down, depressed, or hopeless has bothered you more than half of the days in the past 2 weeks?" So if the patient says yes, then show the cue card and ask whether it bothered them for nearly every day, 12 to 14 days, or on half or more of the days, 7 to 11 days. So if the patient says no, then show the cue card and ask them whether it bothered them several days, 2 to 6 days, or never or 1 day, 0 to 1 day. Next, there is probing. When probing, you respond to a non-committal response, such as "not really," by gently encouraging the patient to tell you if the symptoms bothered them. even if it was only some of the time. Now remember, probing should be done by asking neutral or non-directive questions. Here are some examples of this technique that you can use when speaking to the patient. What do you mean? Tell me what you have in mind. Tell me more about that. Please be more specific. Give me an example. Disentangling. Disentangling is a process that the interviewer does to take longer items and separate them into shorter parts, providing the patient the opportunity to respond after each part. Now, this method is helpful if a patient has a moderate cognitive impairment that can respond to simple and direct questions. So here's an example. For D0150C, trouble falling or staying asleep or sleeping too much, break the item down as follows, asking each question and then waiting for a response before asking the next. In the past 2 weeks, how often have you been bothered by having problems falling asleep? And then you'd wait for a response. And then you would ask, how often have you been bothered by having problems staying asleep? And then you would wait for that patient's response. And then you would continue. How often have you been bothered by feeling you're sleeping too much? And again, you would wait for a response. And finally, there's echoing. Echoing is where you summarize longer answers to interview items by narrowing the answers to the response choices available, and then ask the patient which response option best applies. So here's a good example. For item D0150E, poor appetite or overeating, the patient responds, oh, the food is always cold and it just doesn't taste like it does at home. The doctor won't let me have any salt. So a possible interview response could be, so you're telling me the food is not always what you eat at home and you can't have salt. How would you say that you were bothered by a poor appetite or overeating during the last 2 weeks? Okay, let's look at D0160 total severity score. The total severity score is a summary of the frequency scores that indicate the extent of potential depression symptoms. Now, the score doesn't diagnose a mood disorder nor depression, but it provides a standard score which can be communicated to the patient's physician, other clinicians, and mental health specialists for appropriate follow-up. And remember, responses to the PHQ 2-9 can indicate possible depression if the full PHQ 2-9 is completed. And responses can be interpreted as follows. Major depressive syndrome is suggested if during the look-back period, 5 or more of the items are identified as a frequency of half or more of the days, 7 to 11 days. Minor depressive syndrome could be suggested if during the look-back period, D0150B, feeling down, depressed, or hopeless, D0150C, trouble falling or staying asleep or sleeping too much, or D0150D, feeling tired or having little energy, are identified at a frequency of half or more of the days, 7 to 11 days. In addition, the PHQ 2-9 total severity score can be used to track changes in severity over time. Total severity score can be interpreted as the following: 0 to 4, minimal depression; 5 to 9, mild depression; 10 to 14, moderate depression; 15 to 19, moderately severe depression; and 20 to 27, severe depression. So consider the steps for assessment for D0160. We need to start by looking at the completed patient mood interview D0150. So do not add up the score while you're interviewing the patient. Instead, focus your full attention on the interview. However, you should add the numeric scores across all frequency items in the patient mood interview D0150, column 2, represented here on this screenshot with the green highlight. Note, there are additional scoring rules that can be found in Supplement D. That is Supplement D scoring rules, patient mood interview, total severity score D0160. And we will be covering those a little later in the presentation. And note, the maximum patient score is 27. The total severity score will be between 0, and 27, or 99 if the symptom frequency is blank for 3 or more items. And as a reminder, the total severity score is left blank if both D0150A1 and B1 are coded 9. Then you would leave D0150A2 and B2 blank in the PHQ2 and leave D0160 total severity score blank. So hopefully this illustration will help in understanding this concept of when only the first 2 items are coded with a 1 or a 0 for symptom frequency. In this case, you would not complete the remaining 7 questions. You would add the numeric scores from these 2 symptom frequencies and enter that value in D0160. With the goal of reinforcing this concept, this illustration depicts a scenario where all symptom frequencies for the PHQ-9 items were scored. So in this case, you would add those numeric scores from D0150A2 through D0150I2, following the instructions found in Supplement D, and enter that score in D0160. And here's an illustration of another scenario, one in which symptom frequency was blank for 3 of the items. And in this case, the interview is deemed not complete. So you would enter a 99 as the total severity score. And finally, a final note here. Supplement D and the IRF-PAI and LCDS guidance manuals provide additional scoring rules for D0160. Now, these rules apply if D0150C through D0150I were asked and describe the following. Descriptions on why column 2 symptom frequency could be blank, how to compute the total severity score with considerations for the number of missed items in column 2 symptom frequency, and examples of scoring the total severity score based on the number of missing values in column 2 symptom frequency. We invite you to review that guidance for specific instructions regarding these situations. And to summarize, D0150 patient mood interview, the PHQ-2-9, is a standardized assessment for depression and mood disorders. Following the steps for assessment and coding for the PHQ-2-9 is essential for accurate detection of possible depression. By tallying the PHQ-2-9 symptom frequency scores, a total severity score can be calculated. D0160, total severity score, can help clinicians detect possible depression and the extent of depressive symptoms. We do welcome questions, and if you would like to submit a question regarding this presentation, please send it to pactraining@econometricainc.com. Thank you for reviewing. We look forward to sharing more insights in the workshop training. Have a good day.